Good afternoon, everyone, and welcome to today's HSR Research in Progress webinar. My name is CB Mamrell, and on behalf of the Systems for Action National Program Office here at the University of Kentucky, I'd like to welcome all of you to today's webinar, which will be focused on cost, quality, and value public health services. Today we have with us one of our directive research consortiums led by Colorado, who will be presenting their work on comparing state dissemination and implementation strategies on local health department accreditation, readiness, and quality improvement maturity. As a reminder to everyone, you can download today's presentation and speaker bios from the resources box in the top right corner of the screen. So I will be presenting and introducing the presenters, and then they will give their presentation, and then we will have commentary afterwards from our guest commentators, and we also give an opportunity for the presenters to respond to the commentary, and then we open the webinar to questions and discussion from the audience. For those who are not familiar, DIRECTIVE is short for Dissemination and Implementation Research to Improve Value, and there were 4 of these directive studies that were awarded to a consortium of 2 or more public health PBRNs in 2014, and these studies build on improved DAX measures and methods. These studies examine the facilitators for implementation of evidence-based prevention programs, looking at the resources and infrastructures, the relationships and inter-organizational coordination, and also assess the quality and cost of public health service delivery strategies. From there, they draw conclusions on the comparative effectiveness and value of services. So today is the 3rd in our series of directive studies presentations, and today we have with us the Colorado, Kansas, Nebraska Directive Research Consortium. So with that, it is my pleasure to introduce our presenters for today, starting with Dr. Adam Atherly, who is an associate professor and chair of the Department of Health Systems Management and Policy in the Colorado School of Public Health. Dr. Atherly's main area of research is health economics, with an emphasis on the economics of aging and consumer decisions regarding health plan and choice and health. Adam has been working in public health services and systems research for several years, with an emphasis on measurement and economic issues and cost-effectiveness studies, with experience in health outcomes research, including scale development and evaluation of efforts to improve quality of care and patient safety. Our next presenter is Lisa VanRaemdonck, who is Executive Director of the Colorado Association of Local Public Health Officials, as well as co-director for the Colorado Public Health Practice-Based Research Network. Lisa's work is dedicated to encouraging public health systems level improvements through strategic partnerships, workforce development, peer networking, capacity building, practice-based research and dissemination, and policy development. Prior to her public health career, Lisa worked in public relations and marketing and has experience with nonprofit and business-to-business communications. Our 3rd presenter is Melanie Whittington, who is a PhD candidate in the Department of Health Systems Management and Policy at the University of Colorado Anschutz Medical Campus, where she concentrates on health economics. Melanie is currently finishing her dissertation that investigates cost-effective solutions to detect and prevent healthcare-associated infections both at the hospital and national level. Melanie is interested in evaluating prevention activities and policies designed to improve health outcomes to determine their cost effectiveness. She is currently employed as a project manager of the Directive project for the Colorado Public Health-Based Research Network, where she conducts evidence-based public health research to determine efficient practices in public health service delivery. So with that, I'd like to turn it over to Adam, Lisa, and Melanie. Lisa, are you on the line right now?
I am. Thank you, CB. Thanks.
Yeah.
I'll get us started today, and then I will pass the presentation wand over to Adam and Melanie. We're excited to share with you some of our preliminary results of our directive project. First, of course, we want to recognize our research team members. This is a collaborative research project, as indicated by CB, among Colorado, Nebraska, and Kansas. And we are very appreciative of all of our research team members, as well as all of the local public health agencies and all of the state-level organizations that have helped us with this project in each of our states. By way of acknowledgments, this is a directive project funded by Robert Wood Johnson, and the research team have no other financial disclosures or conflicts of interest. Just a quick overview of what we'll talk about today. We'll give you a brief overview of the project. We'll share the entire project and then hone in on a couple pieces of our preliminary results focused around quality improvement maturity and our quality improvement inventory. So in terms of an overview of the project, the entire project is based on this, watching this system-wide national transformation of public health related to accreditation, national voluntary accreditation by the Public Health Accreditation Board, and the movement towards quality improvement. And so we know local public health agencies, many of them are preparing for accreditation or have already become accredited, but we also know that even those who are not interested in accreditation at this time, many of them are engaging in quality improvement activities. And so we're looking at both of those pieces. What we also know is that across the years, even prior to the creation of FAB accreditation, that there's been a varied level of support from state-level partners to local public health agencies to support them in their efforts both in quality improvement and in accreditation. So we're looking at that interaction between our local public health agencies and state-level partners. We do hope that this research is relevant to all local public health departments and hopefully state health departments as well in their creation of this culture of performance measurement and in the increased use of evidence-based decision-making, and hopefully relevant to our state partners in their understanding of creating their best role in supporting local health departments that are doing this work. So what do we mean when we talk about these system-level partners? So first, we think about the activities and initiatives that state-level partners engage in with their local public health agencies in their states. These are things like training, technical assistance. Sometimes it's direct funding. Sometimes it's learning community facilitation. These are the kinds of activities that we're looking at. And what we know is that these activities have been clustered and funded in a variety of ways across the past several years. And so you may be familiar with some of these initiatives like the National Public Health Improvement Initiative, or NIFI, the NACCHO Accreditation Initiative, the Multi-State Learning Communities, the Gaining Ground Initiative, which is currently going on. State health departments have used their preventive block grants to provide direct funding and also resources and technical assistance to local public health agencies in this work. But what we found is that there hasn't been a lot of research comparing these system-level initiatives and understanding how the investments in them might lead to differences in QI maturity and accreditation readiness. There certainly have been evaluations of some of these initiatives, but we wanted to take a little bit more holistic research perspective. So our project goal is to examine and compare the interactions and differences in local health department measures of AR and so accreditation readiness and QI across our 3 states, Colorado, Nebraska, and to examine the differences in the financial investment, so the dollars that go to do these QI projects in local health departments, and then also to examine the connection between QI projects and actual measures. So this is our connection to the MPROVE project that we'll describe a little better. So here's the visual. So if you haven't tracked yet and you're a visual person, this hopefully will be helpful for you. So we started with, on the left-hand side, the idea of these state-level structures, these state-level partners that are engaging in state-level initiatives to support, on the right side, local health department work in quality improvement and accreditation readiness. So that's sort of the frame upon which we are adding some measuring and some research. In the area of local health department quality improvement, we're looking at quality improvement maturity as a measure, or as a set of measures, and we're looking at quality improvement inventory. So the inventory is really what have you actually done in terms of quality improvement projects. And then both of these areas, we think we are trying to connect them because we think that they do connect. We're trying to connect them to service measures that have been selected through the MPROVE projects. So this is a national effort a couple of years ago of several of our PBRNs to come up with some uniform service measures for local public health agencies. So you'll hear a little bit about how we're using that to try to tie the activity of QI and the sort of accreditation readiness of the health department to actual changes in services and outcomes. Then there's a few other pieces to the project that we won't get into much today, but we'd love for those of you that are interested to catch up with us in about 8 months to find out where we are. We are looking at the investment, specifically dollars, but also in-kind resources by the state health or the state agencies, state organizations into local health departments. We're also looking at the network connections, so using questions from the partner tool with Danielle Varda out of the School of Public Affairs at the University of Colorado to understand the network and relationships between these state entities and local health departments and see if some of the relational pieces actually drive QI maturity in a different way or accreditation readiness in a different way. And then lastly, another piece that we'll be looking at in the future but not talking about much today is the cost of QI projects. And so through our QI inventory, we've collected a set of QI projects, and we'll be able to do some retrospective cost analysis of those projects. Just to get a little bit more clear about, before we move on, about these state-level implementation structures, because I understand that can feel really vague. What we're really talking about here are initiatives and activities that have come out of state health departments, public health institutes, SACHOs, so places like CALPHO, state associations that are the state affiliate of the National Association of County and City Health Officials, APHA affiliates at the state level, and public health training centers. So these are entities that exist in many different states and at different levels and different fundings and in different ways at the state level. But we see those as the main key partners who have access to and expertise in, access to resources and expertise in this QI maturity and accreditation. So with that, I'm going to pass it over to Adam, who will talk us through a little bit of our findings in the area of quality improvement maturity.
Thank you, Lisa. So I'm going to talk a little bit about the quality improvement. And again, going back to Lisa's conceptual model, as she said, this is a pretty complicated project. We're collecting quite a lot of different kinds of data, and then we're combining it in different ways. So I should emphasize as we begin talking about this that this is preliminary results that we're working through right now. So I want to talk a little bit about the QI maturity piece of it. We're using the data in a couple of different ways that I'll show you as we go through. First starting with the research side, the research question we asked on this piece was whether or not health departments in states that had more system-level investments and initiatives for QI have, as a result, higher QI maturity and less heterogeneity between local health departments serving different population sizes. And again, the idea here is that if the state is investing in QI sorts of activities, that there would be two effects. One is that the average health department, that is the average level across the state, should be higher in terms of QI maturity. And the other thing is that we know there's a lot of that different local health departments have very different resources available to do things like QI. And so you would expect, for example, local health departments in smaller areas may not have the resources to do QI activities in the same way that larger agencies might. So if the system is making investments, that is, you're having state-level investments, then what you would expect to see is smaller differences between smaller and larger agencies. So the question we're asking is just, are those two effects in fact there? To measure quality improvement, we used a validated tool of QI maturity. It was created by Brenda Jolly and amended by the Minnesota Department of Health. And in fact, Beth Gerlstrom, who is one of the commentators, is one of the key people who helped develop this instrument and was very helpful to us in providing us the instrument and talking to us about scoring and all kinds of useful things. So it's a tool that you can fill out. It's self-report data, and there's 3 different domains, which we'll talk about a little bit as we go through, and I'll give you some examples of the questions. But the 3 big areas that we're trying to measure in terms of QI maturity are the organizational culture. So again, the idea would be whether or not the agency values QI and whether or not QI is something that is important to the agency. The capacity and competencies. So does the agency have does the agency have the skills and really do QI sorts of activities? And then finally, alignment of spread about how widespread are QI activities within the agency. In terms of data collection, again, this is a 10-instrument tool, and we gave this to local health directors. So we sent the survey out, and so the data that we're going to show you very much represents the perspective of local health department directors regarding their level of maturity for quality improvement within their agency. And we did our sample with local health departments in Colorado, Kansas, and Nebraska. And with the help of our partners in Nebraska and Kansas, we managed to get 100% response rates in both of those states. So 100 local health departments in Kansas, 20 in Nebraska. We got a 67% response rate in Colorado. So overall, we got 156 responses. The survey was in the field about this time last year, so January to March in 2015. Okay, this is a picture of the 10 questions that were asked. And again, as I said, there's 3 different domains that we're looking at: organizational culture, capacity and competence, and alignment and spread. And again, I don't think we want to go through the questions directly, but this will give you an idea of the kinds of things we're trying to measure. And what we do with this then is you take the answers to the different questions, and all the questions are asked in the same way. They're on a 5-point Likert scale. And people fill out it, so you have a possible response which is scored between 1 and 5, and then we sum up the scores within the different domains to create a score for each of the 3 subset domains. And again, the idea would be if you have a score of 5, you've got the highest ratings, and as you get lower, your score gets lower. That's a lower rating for your organization. Now, I'm talking about the research side, but I should emphasize that we really have 2 purposes here in collecting this data. One is the research results, which I'll show you, and the other thing is that we wanted to have this be useful to our practice partners. So we took the results and we actually developed individualized reports for all of the local health departments, which we fed back to them. And so we essentially took their scores and we sort of said, here's how you scored and here's how peer agencies scored. And that's already been, that's given to local health departments. And Lisa at the end is going to talk about how we use that data in terms of our dissemination to our partners. Now, switching back to the research side then, what we did, again, what we're interested in is we're interested in understanding why different agencies will have different scores on these QI maturity tool. And so we looked at it in a couple of different ways. We did an ANOVA, just trying to look at some differences. And then we also did a regression where we tried to explain differences in QI scores based on the population of the local health department, based on the state, and then based on some interactions between the population and the state. And the idea is, our hypothesis is that local health departments and states with more system-level investments in QIs should have both higher QI maturity scores and less heterogeneity. And that really translates to us thinking that Nebraska, which had higher-level system investments, should have higher scores and less heterogeneity. So in terms of descriptive statistics then, what I'm showing you here is the different QI scores for overall QI maturity. So this is average, or the median QI maturity score for the 3 states, and then the average for each of the 3 different subdomains. So you can see the highest scores overall was for organizational culture, and those scores are actually very consistent across the 3 states. And the lowest scores tended to be for capacity and competence. So again, the idea of whether or not the agency had the skill set. And there you see quite a bit higher score for Nebraska than the other 2 states. And I might say higher, I mean statistically significantly higher. And this is the same thing by population. And again, you see the same thing, that the reported culture is actually, there's no statistically significant differences by population size served by the local health department. And the same thing in terms of alignment and spread, there's no real differences. But in terms of the capacity and competence of the organization, in terms of doing QI activities, there we do see a statistically significant difference. And when we look at it, when we put this into a regression model, we see the same basic story. We see a higher level of capacity and competence in Nebraska, which is what we anticipated, because again, Nebraska has the system level investments. And then we, although we're showing it here as being insignificant, there's sort of a borderline significant decrease in heterogeneity within Nebraska, suggesting that Nebraska has not only increased the overall level of capacity and competence through their system-level investments, but they've also decreased the amount of heterogeneity across agencies in different population sizes. You know, this is, again, I want to emphasize, this is very much preliminary analysis. There's a whole lot of things we're worrying about as we do the statistical analysis. We're worrying about issues of endogeneity, or for those of you who do epidemiology, unobserved confounders. And we also, again, obviously we have in Colorado, we've got a lower response rate than the other two states, so we've been looking at potential problems with response bias in Colorado. And so we've actually done analysis of that, and we don't see any statistically significant differences between responders and non-responders in our survey. But we're, again, still looking at that question. So when you look at the conclusions, again, of this piece of the result, again, we do see higher scores for QI capacity and competence in Nebraska and lower heterogeneity in Nebraska, which is consistent with our theory that system-level investments will increase maturity and reduce heterogeneity. There's lots more to do, though, as we're going through here. And I will turn it over to Melanie now.
Great. Thank you, Adam. So now we're going to transition to talking about one other portion of this project, which was the creation of the quality improvement inventory. And going back to the conceptual model that Lisa presented, the QI inventory really has three main purposes. One, for us to identify what kind of QI projects are being done in our three states. But this QI inventory will also inform two other aspects of the project. One, we will select a subset of these projects from our QI inventory for the cost component in determining the cost of these projects, but also we'll use the projects in this QI inventory to identify improved measures, and that's what I will be talking about in an upcoming slide. For the QI maturity survey that Adam just discussed, we added a question at the end that asked how many QI projects has the local health department completed or started in the last 3 years. And then we sent the QI inventory to all of those agencies who said they had completed or started at least one QI project. The inventory we created consisted of a subset of questions from the PHKICS, the Public Health Quality Improvement Exchange, and the questions were largely centered on the time frame of the project, a summary of the project, who the collaborating partners were, and what QI method and tool were used. And Lisa will talk about in a bit, too, how this inventory was disseminated and used by our partners. And so then we use the projects in the QI inventory to map them to potential improved measures that would be impacted. And to do this, we first looked at what public health service or activity would likely be most impacted by that QI project, and then map that public health activity to those improved measures. Looking at the results of our QI inventory, we had 42 QI projects, 22 from Colorado, 9 from Kansas, and 11 from Nebraska. And as with many things in practice-based research, in theory it seems pretty straightforward that we could link these projects to public health activities, but in practice it proved to be a little bit more challenging. And we found out that really the majority of these projects were more agency process improvements, or designed to have a broad impact than rather impact one specific public health activity, which was one challenge that we had to overcome. But of the QI projects that we could more clearly link to public health activities, you can see which public health activities they were linked to and the number per public health activity on this slide. And I think it's clearly evidence that the largest percentage of these were mapped to immunizations. So when thinking about our improved measure selection, we selected the immunization improved measures for really two main reasons. One, the QI projects here could be very clearly linked with immunizations, and that wasn't necessarily the case with other public health services. Also, every state in our consortium, Colorado, Kansas, Nebraska, had a project that could be linked to immunization. There are two improved measures. Immunization improved measure 1 looks at the proportion of children vaccinated with a complete series as required by state law upon entry into kindergarten for the most recent school year. And then our second measure looks at the number of immunizations actually administered by the local health department to children 0 to 5 and children 6 to 18 during the past 12 months. And so we are collecting data right now at the state level in all 3 of our states. We're collecting information on these two improved measures before and after the QI project. And then we can look to see if there were changes or positive changes in those states that had a QI project related to immunizations. And so now I will turn it back to Lisa to talk about dissemination to participants.
Thanks, Melanie. And I can quickly answer Susan's honors question about our specific definition of QI. And so today you did hear a lot about QI as a QI project. But when you look at the way that the QI maturity tool was created, it's a lot more about QI culture than it is about individual QI projects. And so the QI maturity tool measure will helps understand a little bit more about things. For example, are your staff encouraged to work across silos, basically, across program areas in order to come up with solutions? Does your leadership support QI and performance measurement, performance improvement across the agency? So that will give us a little bit more than just the QI as a QI project kind of measures. Hopefully that's helpful, Susan. So dissemination to participants. So you heard a little bit of where we're going with the dissemination to participants and to our local health departments. And we really are in Colorado focused on the practice part of practice-based research, and because CALPHO, as the state show, as the Association for all the local health departments, is so involved in this kind of work, it means that we're just really attuned to doing research work that's, while we're in the middle of the research and at the end, immediately usable by local health departments. So we were excited to be able to create these quality improvement maturity customized reports for all 156 health departments that participated. And those reports, you saw just a little snapshot, they give information about the individual public health agencies' results in comparison to the entire state and in comparison to a subset of the state based on what our state team members thought was the most appropriate for their state. So as an example, in Colorado, we looked at the population jurisdiction. So if you had a population of 30,000, you would get your results from the Quality Improvement Maturity and Accreditation Readiness questionnaire in comparison to the whole state, and then in comparison to local public health agencies in Colorado that have a population of between 25,000 and 100,000. So that was both great to look at in terms of an individual health department, but then as the state show and thinking about our state level understanding of the maturity of our local health departments, it was also just very helpful for us to think about across our whole state where our public health agencies are in QI and accreditation work. And then our quality improvement project inventory. So each state, we're still working on this, but each state's going to get a very simple but searchable Excel file of all of the QI projects within their state. So that it includes contact information for each person at the local health department that is kind of the lead in QI or was the lead on that individual project. So hopefully our state partners and our local partners will be able to use that as a way to reach out to each other and learn from each other more details about individual QI projects. And then here in Colorado, we are a gaining ground state, as is Nebraska. And in Colorado, we're actually using our collection of the QI project inventory from Colorado as a component in a training and peer learning initiative that we have in Colorado, where we've brought together 18 health departments, about 60 or more individuals to share amongst each other about and learn about individual quality improvement tools. And we're using the project inventory as a basis for some of the sort of case study conversation in that peer learning. So again, it's been an immediate, able to be immediately used. So next steps, we have a few other things that we've been doing simultaneously. There was an entire section around accreditation readiness that we didn't present today, but we're working on a factor analysis around that. We did conduct interviews with our state-level partners to understand the QI environment need in each state. So when we get the results like we did about Nebraska, we can look at, well, what's different at the state level in Nebraska? How are they providing a different level or a different amount of services than in or technical assistance in Colorado and Kansas. And the next one was also collecting quantitative data on that. So knowing how much money, in some cases, was given from the state entities to the local health departments in order to support this work. So you saw the 3 blue boxes in our conceptual model of the project. So there's a few other things that we're working on, including the network analysis of those connections between local health departments and state-level partners, and that's ready to go out the door as soon as we get IRB approval. And we're also looking at determining the degree to which the system-level investments, the dollars, and those initiatives that come from the state level into the local level relate to the QI maturity and accreditation readiness together. And then you also heard the estimating the cost of implementing the individual QI projects through that sort of retrospective look and connecting to our immunization improve measures. So we have a fair amount of work left to do, but we're well on our way and we've got a lot of work under our belts. Let me answer Mary's question really quickly before we get to our esteemed commentary folks. So accreditation readiness, when we looked around, when we started this project a couple of years ago, there really wasn't a singular tool that we felt comfortable using on accreditation readiness, so we created our own. And we used a combination of questions from the NACCHO profile, questions from the FAB checklist about are you ready for accreditation, simple things about the prerequisites. And I will say these are the prerequisites for the previous set, so just the CHA-CHIP and strategic plan. So this is not the new prerequisites. And we compiled those into a questionnaire of about 10 questions as well. So that's a custom-made questionnaire to try to understand accreditation readiness. It has some questions about if you're Board of Health and if your Executive Director support going for accreditation. And a couple of questions about even if you have the technology, so do you have the capability of collecting all of the documentation in a digital format? So it goes through those kinds of questions. Hope that's helpful, Mary. And CB, I think I'm tossing it back to you for moderating the commentary.
No problem, Lisa. Thank you so much. Thank you, Adam. Thank you, Melanie. And before they give their commentary, I'd like to introduce our commentators for today's presentation. Our first commentator will be Dr. Elizabeth Gilstrom, who is a senior research scientist in the Public Health Practice Section, Health Partnerships Division, Minnesota Department of Health. Beth is trained as an epidemiologist, and she has extensive experience working with state and local public health data. Previously, she worked in the MDH Center for Health Statistics with a focus on maternal and child health research. She's also been principal investigator or co-PI of several public health services and system research studies and staffs the Minnesota Public Health Practice-Based Research Network. Currently, Beth is the PI on a multi-state Robert Wood Johnson Foundation funded study examining the relationship between primary care and public health practice-based research networks at the local jurisdictional level. Our second commentator will be Sinden Jitsi, who is the Community Assessment Manager at the Tacoma-Pierce County Health Department in Washington State. Sinden leads the department's quality culture and performance management initiatives through its Office of Assessment, Planning, and Improvement. Sinden also serves on the expert panel for the Public Health QI Exchange and leads the Public Health Centers for Excellence, which provide training and technical assistance on all things quality and accreditation to health departments across the country. So with that, I'll first turn it over to you, Beth.
Great. Thank you very much, Colorado, Nebraska, and Kansas Practice-Based Research Networks. This was a great presentation, and I appreciate the opportunity to reflect on your work. You know, this study is really timely and important, I think, both for researchers and practitioners. First, it's becoming more and more evident to me that having PBRNs work together to build on previous studies, such as IMPROVE and DAX, is really important to further enhance and develop our field. And this multi-PBRN approach really promotes standardization of research methodologies across states. And over time, and as an improved state, we saw firsthand really how varied data collection can be across states and the need for better standardization to support valid research conclusion. Over the past several years, there's really been a growing awareness that performance management and quality improvement activities are a critical component of enhancing the quality of public health service delivery. And this has really been paired with the emergence of National Public Health Accreditation and its stated goal of improving health outcomes by transforming public health at all levels. So for us in Minnesota, these studies are really of particular interest and relevance, given our past studies of organizational QI maturity at the state and local level. And we're really pleased that the QI maturity tool, the 10-question subset, has been able to be used successfully in 3 of our fellow PBRN states. But even more excited that you have the statistical power to really use the scoring and delve deeper into how QI maturity may be related to local health department capacity and health outcomes. As a state health department employee, we have contributed significant state health department resources to support our local public health agencies in increasing their organizational QI maturity and to support accreditation readiness, but we really don't have adequate sample size within Minnesota to fully assess the impact of this work. So, first off, just seeing your preliminary analysis that suggests that Nebraska's investment has led, both to, at least in that capacity and competency domain, these higher scores, but also less variation does really support that role. And I think looking at your future analysis, I think that your study is going to be very relevant to our continued technical assistance role at the state level, and also really highlighting the need for ongoing resources to support such efforts. Building local capacity and infrastructure can be kind of a difficult sell to policymakers, yet we really believe that stable, flexible infrastructure funding is critical to supporting local capacity and decreasing this observed variation we see across our local jurisdictions. So, we're kind of anxiously awaiting your further results because I think could provide some valuable data to support that message. I believe that maybe one of you told me at some point that you had embedded these measures into existing data collection efforts in a couple of your states that had the 100% response rate. I just wanted to comment that I think that's a really effective way of both strengthening the validity of the study itself, but also lowering your burden on your local respondents. So I really think that's a model for our future research studies as much as possible. And the state practitioner in me really appreciates your commitment to disseminating results back to your participants. Really critical step, practice-based research. We do that here in Minnesota. We administer our the QI maturity tool to our local health departments annually as part of a larger reporting system. And we do provide them with individual results, and now we've been able to provide them with some trend data. But we're seeing that feedback loop really has helped elevate the importance of collecting the data, but also that provides them with some important information they can use internally in their organizations. Although in looking at your report, I kind of feel like we might want to borrow or perhaps build or model on some of your formatting. That's really, really nice. So I just want to say I really enjoyed the presentation and hearing this first round of results, and really look forward, though, to seeing a lot of your future work, especially around the QI maturity, accreditation readiness, and the improved immunization measures and cost piece as well. And I know you do have kind of a long to-do list of future analyses, but if you thought that you could sneak in perhaps some additional validation of the 10-question subset, I believe the full Brenda Jolie tool was administered maybe in one of your states. So if you thought that you would have some time for that on the side, we'd certainly be out of interest. But thank you for a great presentation, and we look forward to seeing you.
Thank you, Beth, and I'll turn it over to you, Sinden.
Great. Thank you so much also for allowing me to comment on this research project. I absolutely second Beth's comments, so thank you, Beth, for your perspective. At the Tacoma-Pierce County Health Department, we've done a lot of work around QI, and if I had taken the QI maturity assessment, I'd probably score us fairly high. We also are expecting our FAB accreditation site visit in March, so that's kind of where we are on our journey of QI and accreditation. I'm really excited about this study, especially the main research question, and I thought a lot about kind of giving a very practice-based, commentary about this as someone working on these issues at the local level. I think your results, just as Beth said, will be really helpful for local health departments and state health departments to understand the benefits of these system-level efforts and, as Beth said, advocate for resources at the state or with policy makers, et cetera, to continue this work. For example, in Washington State, we were an MLC state from the beginning. We received, the NIFI funds, and we had done a lot of systems-level capacity kind of work, especially during the NIFI grant. And when the NIFI grant ended, a lot of that work stopped. And one piece of that, the Public Health Centers for Excellence work that you heard about in my introduction, we in the Spokane Regional Health Department, or Health District, 2 local health departments, are trying to continue that work, but we had to move to a fee-for-service model versus a grant-funded model, which really diminished capacity. It broke apart that systems-level approach and, caused a decrease in requests for these services now. And so I suspected all along that the systems-level approach was much more useful, and I think now we have some hard data and research, behind that, understanding these are preliminary figures. But it's just really exciting to see some data back this perception that we had, back it up, and we can use this to advocate for more systems-level work. So thank you for your efforts. Also, the sample report, I thought that was fabulous that you're giving that to your local health departments. I especially love that you tied in with the NACCHO QI roadmap. That's a wonderful resource that's out there for local health departments, and I think it's great for when research and practice-based work around QI accreditation support existing resources already out there instead of recreating the wheel. So I thought that was wonderful. And we have been using a non-validated tool to assess our QI culture and QI maturity, and I really am going to bring this 10-question tool now to our QI structure, we call it a quality coordinating team, and let them kind of think about what the pros and cons would be to switching over to this type of a tool. What I like about that, then we can compare ourselves to other local state folks. So thank you for your research on that tool. We've been waiting for a nice, simple, short tool, so thank you. Just in terms of thinking about moving forward, I think the more, again, as you send out more reports and make the reports useful and helpful for your locals, I think the more we can link to more web-based resources to support, like the identified opportunities. I know you weren't able to show the full report, but when I looked at it, what I loved about it was that there was a summary of strengths and opportunities for each local health department. And for those opportunities, the more that we can point people to existing web-based resources for them to work on those opportunities, I think the better off and the most useful those reports can be. And then finally, we actually had a little email conversation about this next point. I think the concept of you don't know what you don't know might be affecting the scores on the QI maturity assessment, especially for the QI organizational cultural domain. So as you heard, this assessment tool is given to the public health directors to self-score. And in our experience, when we started using, albeit a non-validated tool to score ourselves, we first started with our management team scoring us, and then we opened it up to all staff. And our managers, our director, our managers, myself, scored us a lot higher than staff did. When we let all staff have an opportunity to score us on our QI culture, our scores dropped. So I think it's probably reliable, but in terms of the validity of the tool, and that might explain some of the reason why I think in that domain, Nebraska scores were actually slightly lower in some areas. And I think it's because once you really get in and you become more mature in your quality culture, you actually are a harder critic on yourself. And so there might be a little bit of that going on in terms of the results that you're seeing. It's an interesting dynamic, I think, and Beth was saying she saw the same thing in Minnesota. So again, not quite sure what to do about that, but we've seen that in our own health department. So thank you so much, and I look forward to the dissemination of the results of this to other local health departments. I'm hoping maybe you try to do an open forum presentation when you have your final results so that you can share this work with other health departments. So thank you again.
Thank you, Cindy, and thank you, Elizabeth. And I'd just like to throw it back again to Adam, Lisa, and Melanie. Feel free to respond to both commentaries. And anything else that you also wanted to add on during your presentation that you feel that you want to add on, just go ahead and do so. So turn it back to you guys to respond.
This is Lisa, and I'll start. Thank you to both of you. And Sinden, you've inspired me a bit. Both with the open forum, because you're right, we really should do something in the fall open forum. But in thinking about, I totally agree with you, and sort of we were a little stuck on this idea of just asking the public health director. And in terms of research burden, we knew that was, the way to go. But and I had thought, well, gosh, if anybody wanted to use it for their whole agency, they could. But that's kind of a lot of work. We do have the capacity, especially through our Gaining Ground in Colorado anyway, and now I'm inspired, to offer up to our health departments if they would like to run it with a group of their staff, that we could do the data analysis for them and produce a report that is that's anonymous, right? So they don't necessarily know, who says what, but that then they have a little bit different, more of a 360 or maybe a 180 picture of their health department. So thanks for that inspiration.
Adam, Melanie, do you guys want to add anything more or respond to the comments?
This is Adam. I appreciate the comments very much. I think some very good suggestions. Being the research person, I particularly like the idea of Beth's idea of trying to compare the longer instrument to the shorter instrument. I think that would, we'll if we've got the data, we'll absolutely do that. We're also, I should mention, doing a lot of work on trying to understand the responses to the instrument. We've already done a factor analysis to try to understand how responses group together. So this is, in terms of the method sides, we're very much trying to look at the instruments and see if we can understand how people are responding better to help guide the interpretation of the results.
And this is Melanie. If I could just piggyback off what Adam said, we agree with Beth that we do actually have in one of our states, they ask the longer set of questions, and then the other two states ask the 10-question subset. So that is also a hope for more of an ancillary analysis, is to look into that a little bit more.
So is it something that, just talking about the broader, dissemination, implementation, implications of your directive study, the tool that probably will come out of it too, and also those customized report, I guess a template for that, is that something that you guys are maybe considering now that, especially in this webinar, has sort of generated a lot of interest from, our audience of collaborating maybe with you guys? Is that something else?
Yeah, if people are interested in using the tool and then creating a report that's similar to ours, I will say it's a bit it's a bit bulky. It's a mail merge between Excel and Word in order to get the report, the 156 reports. So, but yeah, we would be happy to share with any states that want to do something like this, the background sort of templates of how to run it.
Excellent. Anyway,
This is Beth, and
go
if I
ahead.
could just interject,
Yep.
the tool itself is part of the PHSSR toolbox. So, you can go in and have people take the tool online currently. I don't think that, I have not seen, exactly the reports that are looking as nice as Lisa's, and hers obviously has a little bit more to it with accreditation readiness, but that is a tool available already online.
Thanks for letting us know about that, Beth, for pointing that out. So now we're going to open the webinar to questions from the audience. We encourage you to type those questions in. Generally, there's a lag, so if we don't get to it, we apologize in advance. You can always direct the questions to the Colorado-led consortium, Lisa or Adam, or you could also forward it to us, and we'll forward it to them too as well here at the center. So I see, okay, Joy Harris is typing a question. I guess moving forward, are you planning to, in terms of your empirical analysis, do sort of the same analytical approach that you did with your QI maturity scores with those accreditation readiness scores, I guess, and try to see how they relate to as well with the outcomes? I guess in this particular case, you're looking at immunization. Is that sort of the general, I guess, empirical approach that you're trying to follow for the next steps?
Yes, and I would just, this is Lisa, I would say it's a little more complex because we didn't have a ready-made tool. We kind of made our own. So we are trying to be really careful about how we score that and making sure that it both makes sense in trying to do some statistical analysis with it, as well as making sense in the future interpretation.
Sounds great. Thank you. So we'll try to forward Joy's question. Okay. I guess here's Joy. We'll take this as our last question. Do you have a guess about the culture for, I guess, the QI culture of the state health department?
Yeah, Joy, thanks for the question. It's Lisa. Yeah, so we actually didn't talk about it much here. We mentioned it very briefly. Engaged every state in the state teams, engaged every type of state-level entity that I described, so state health department, et cetera, in a key informant interview to do sort of with a qualitative bent to it, and asked questions about leadership of that individual organization in QI and accreditation, and especially with the state health departments. That's where we gathered information about whether the state health department themselves are going towards accreditation or working on QI internally. We have that kind of information from every state-level entity in each of the states, and that's where we're looking at some qualitative analysis to try to be able to describe what the state level, not just culture, but also leadership and resources look like. Adam, Melanie, anything else to add there?
No,
just
Lisa, this is Adam.
Go ahead, Adam.
No, I was just going to say, no, I think that's well said. So I'll let Melanie go from here.
I don't have much to add, but yes, to kind of add on to that, in our qualitative interviews, we asked questions about the state support at the health department level, the governor level, any legal restrictions, and any other environmental factors that they think would affect QI or AR.
And we actually asked them about each other. So one of the questions is, who in your state is a key leader? And in some cases they said, well, it's us, right? And in some cases they said, well, actually, the state health department. So we have a little bit of qualitative anyway, back and forth. Are there multiple leaders? Is there one main leader within, the components of state organizations in this? So we're still figuring out how to quite analyze that and capture it in a way that can help us interpret what we find in QI maturity and accreditation readiness in local health departments.
All right. So with that, I'd like to thank you again, Lisa. Thank you, Adam. Thank you, Melanie, for your time and your wonderful presentation today. And we'd also like to thank our commentators, Beth and Sinden, also for your commentaries too as well. And we'd like to thank everyone who joined us today's webinar. We'd like to remind you that we have an upcoming webinar next week on February 25, Thursday. And again, another presentation from one of our directive studies. And today's presentation and our also past presentations are also available for download from our center website too as well. So giving you back more than 5 minutes of your time today, and we thank again our presenters and our commentators, and thank you for joining us today's webinar. Have a great